Hi guys. This chapter we're going to talk about urinary elimination. I'm going to apologize ahead of time because this will be a little bit longer lecture. There's about 60 slides that go with this lecture. Not all of them will have a great deal of content with them, but they're important to the lecture. So here we go. So this picture here is of the normal structure and function, and we're going to talk about the function of the urinary system in just a few slides. So we need to know that urine elimination is dependent on factors such as what we eat, what we drink, medications we take, and we also have fluid loss with breathing and perspiration. We know that the healthy adult eliminates approximately 1.5 quarts of urine each day, and effective elimination of liquid waste requires proper functioning of all the organs that encompass the urinary tract, and this includes the kidneys, the ureters, the bladder, the urethra, as well as the muscles of the pelvic floor. So the urinary system is responsible for the absorption of nutrients and fluids that we take within our body. It helps control blood waste, and it removes byproducts such as urea, and it conserves other useful substances. Urea is produced when we eat protein-rich foods, and the urinary system also helps control blood pressure and plays a role in the acid-base balance. So we're going to talk about the kidneys. We know that the kidneys are the major excretory organ of the body. It filters liquid waste from the body. It can help balance salts and electrolytes within our blood system. It can help regulate blood volume as well as blood pressure. They produce erythropoietin, which is essential for red blood cell formation. They help synthesize vitamin D, and that helps with our calcium levels. And they play a role in acid-base balance of extracellular fluid. We know that urine formation is done in the filtering units of the kidney called the nephron. And we know that each nephron has both a renal corpuscle and a renal tubule. And these corpuscles are capillaries, the glomerulus, which are surrounded by the Bowman's capsule. And within the renal tubule, we have three components of that: the proximal, the loop of Henle, and the distal convoluted tubule. And they all excrete and retain different things in different areas, and so they each have a role in waste regulation and urine formation. We know that there is filtration that occurs initially in the glomerulus when fluid moves across the membrane, resulting from a pressure difference. There is also reabsorption that occurs in the renal tubules. Most filtrate moves back into the blood, and then what isn't reabsorbed is excreted in the urine. So we look at the normal structures and what are their functions. So the ureters, they carry urine from the kidney to the bladder in the ureters. The wall muscles of the ureter tighten and relax, and this moves the urine down into a downward fashion into the bladder. And urine is retained, if urine is retained in the kidney or backflows from the bladder, then our patients are susceptible for kidney infections. Then we have our bladder and urethra. We know that from the ureters, the urine will go into the bladder, when the bladder here is located just below your umbilicus and above your symphysis pubis. It's a storage unit. The walls relax and expand to store union and contract and flatten as we empty through the urethra. There are sphincter muscles at the base of the bladder which keep urine from leaking, and women as they age or have children have some weakening of these sphincter muscles, which is why we get stress incontinence or urgency incontinence. And we know that the urethra is what transports the urine from the bladder to outside of our body. Pay attention to the quick quizzes. There is the process of urination. The bladder sends out signals when it's time to urinate, which is emptying of the bladder. We get the urge or the urgency to empty our bladder. And there are brain signals that cause the bladder muscles to tighten and the sphincter muscles to relax, and this allows the urine to leave the bladder via the urethra. The process of urination by another term, is called micturition. So some characteristics of normal urine. Urine can either be dilute or very concentrated, and this can happen either from our fluid status, how hydrated or dehydrated we are, or the functioning ability of the kidneys to filtrate or not filtrate things when they're making urine. Urine is a sterile fluid. It's going to contain fluids, salts, and waste products. But always remember, urine should be free of bacteria, viruses, or fungi. So if those are present, then there is something that is not going right with the urine. And urine can be produced in various amounts, and that the average person makes approximately 1 to 2 quarts per day. So there are altered structures or altered function. So we can have alterations in elimination. That might be in normal elimination. We might have urinary retention, or perhaps we have loss of voluntary control, or we might have incontinence, those types of things. And some factors that affect the structure or functioning of the urinary system could be psychological, the food and fluid we take, if we've had surgical or diagnostic procedures, perhaps we have a pathological condition, or we have a urinary tract infection going on. So some abnormal patterns, these are just definitions. I'm not going to read each one of them out to you, but I would encourage you to remember them. You could see them, and you will need to use them when talking about patients and know what they mean. So anuria is the failure of the kidneys to excrete urine. This results from any process that limits the effective blood flow through the kidneys. This diagnosis is made generally when a catheter is placed into the bladder and there is no urine present. An acute anuria can be life-threatening and requires emergent investigation as to why the kidneys are not producing urine, because you will have waste development within the person's body of toxic things, and electrolytes will be out of balance, and this can result in coma and sometimes death. Patients can have procedures such as dialysis. Dialysis is when fluids and molecules pass through an artificial semi-permeable membrane and do a resemblance of what the kidney function is, and this is and it's filtered. There are 2 types of dialysis. The first is hemodialysis, and this is when the patient's blood flows continually from the body through a vascular catheters to the dialysis machine. Your patient will have what we call an AV shunt, generally in their forearm, to allow access to both arterial and venous blood. And the blood flow will go through the machine's filters, and it will filter things out, and then it will be returned to the patient's body. And often patients with chronic renal failure are on hemodialysis. Often they have to go 3 times a week and perhaps more. Patient can also get what's called peritoneal dialysis. This is performed by instilling a dialysis solution into the abdominal cavity through an external catheter. The fluid sits in the abdominal cavity for a specific amount of time, and with the fluid in there, things are pulled into the fluid, electrolytes and volume, and then the fluid is drained from the person's body for that. This is a picture of what hemodialysis might look like. A patient can also have oliguria, which is defined as a reduced urine volume. So you can see for infant, child, and adult, the amounts are different because their percentage of body water and their body mass are different. So this can be a symptom of either chronic or acute renal failure. And we assess this when we're monitoring urine output, and we'll notice this. We can have pre-renal, which results from a reduced blood flow. We can have renal, which there is damage to the kidney itself, or post-renal, which can be from an obstruction of urine flow within the system that brings urine out of the body. So safe practice alerts to be aware of, that measuring and recording INO is part of our care and is almost all hospitalized patients do get I&O, and this allows us to determine whether or not the patient may be retaining fluid or having problems with excretion of fluids. Patients with acute or chronic renal failure may often, or even congestive heart failure, might be placed on a strict fluid restriction, and will have orders for us to maintain strict I&O records. So you can have polyuria or nocturia. Polyuria is an excessive volume of urine formed and excreted every day. This is when an adult excretes more than 2,500 milliliters of urine per day. Nocturia is excessive urination at night or awakening several times. This can disrupt a sleep cycle and is often associated with medications such as diuretics, or perhaps a patient might have a urinary tract infection, cystitis, or even diabetes. You can have dysuria, which is painful urination. There are many causes to dysuria. Generally, the patient complains of burning when they have to urinate, and they might delay in initiating voiding because of this painful urination. Hematuria is when you pass red blood cells in your urine. Sometimes you can see them in your urine. Sometimes they'll be microscopic and only seen when we strip some urine. Urine color does not reflect the degree of blood loss, and there are possible many causes to blood loss in the urine. There are different types of urinary incontinence. So these are the different types that a patient could experience. So again, I'm going to ask you to be familiar with these definitions. I'm not going to read them to you. But they do come up, and you're responsible for understanding understanding these definitions. And we can also have urinary retention, which is when the bladder fails to empty. It can be caused by either an obstruction within the urinary tract system, or perhaps the patient has a neurological disorder. You might see this in high-level paraplegics. You might see this in ones that have C-spine injuries and other neurological disorders. So they may have difficulty starting a stream or even emptying their bladder. Their urine flow is generally very weak, and they may have chronic or acute pain. If it is acute and the patient has never experienced before, that patient needs to be worked up quite rapidly. So there are factors that affect our urinary elimination. They can be pathological or surgical, and this can affect urination either temporarily or permanently. It can also be from medications, food, ambulatory ability, the muscle tone, and urinalysis is the involuntary passing of urine. Often is seen sometimes with bedwetting or passing urine without even knowing that you're doing it. And it can be caused from structural or pathological, but it can be related to non-urinary problems such as constipation, stress, or an illness. So we always consider diversity when we think about the urinary system. So like with age, we want to remember that sometimes that children have a full bladder between ages 3 and 5, and many get nighttime control by the time that they're 5. We also need to know that childbirth can weaken the pelvic floor, and this can lead to stress incontinence. Pregnancy, we know that there's an increased circulatory workload during pregnancy, and this can increase the workload on the kidneys and cause an increased urinary output. And we know that there's a hormone released during pregnancy that causes relaxation of the bladder sphincter. Culture can have influences on many patients, may not seek treatment for urinary related difficulties. Some cultures have an effect on the caregiver's ability to meet the patient's needs. Some cultures may not want opposite gendered individuals caring for patients that have urinary issues. And privacy concerns may vary culturally, but we need to know that often urinating is a very private matter. There may be disabilities that lead to urinary incontinence or retentions. Often paraplegics are taught to empty their bladder using a straight catheterization to avoid retention. There's often lack of privacy within the hospital, which can lead to incontinence or retention. And sometimes there's not significant time for a person to be able to void, and this can lead to changes in their normal elimination patterns. And we know that pressure can cause inadequate emptying or incontinence. There are other factors affecting urinary elimination. We know that developmentally that there are issues related to that. We know psychologically. Some patients may not want to void with the nurse in the room. They might not want to void in the hospital. Those types of things. And this can cause urinary retention. We know that food or fluids can change up medications, and the muscle tone of our bladder floor or of our bladder can affect our urinary elimination. We know that there are surgical and diagnostic procedures that can be done, can affect it because it can decrease the ability because of swelling. Postoperative bleeding can change the color or the quantity of urine, and anesthesia can contribute to retention, decreasing awareness of someone's need to void. Think about this with an epidural and those types of things. There are pathological conditions such as dehydration, and there are some pathological conditions that could result in having your bladder removed, such as bladder cancer. And in that case, bladder urine would need to be diverted out of the body a different way. Infections such as UTI. E. coli is the most common bacteria. More than 1 million hospital admissions are related to UTIs, and they can occur in anyone, and 30% of women have experienced at least one UTI within their lifetime. There are some other factors related to urinary elimination. A person could have a urinary diversion, and this is where they make a subcutaneous way for the urine to leave the body from outside the body. And this is just an example of what those procedures might look like. Another quick quiz. Pay attention to the questions. So now we're going to talk about assessment. So in our initial assessment, we're gathering subjective and objective data. So we're going to consider where the patient is physically, what they're able to do, and mentally where they are in their thought processes, such as their level of consciousness, restlessness, those types of things. We need to prioritize immediate problems that are identified. We need to address relief of symptoms if needed before the full assessment is complete, such as pain and other needing to void. And we need to note if the patient is having any signs of distress or within the patient's orientation. Fatigue can be a complaint of people with kidney disorders. And so then we're going to inspect the urine as well if we can see it. We're going to ask the patient about their urinary elimination pattern. Are they having any abnormalities? Are they sensing any difficulties for them? And we want to review their medications. These might be some health assessment questions you might ask a patient when you're doing your assessment. These are some more. So another way to assess urinary elimination is the use of a bladder scanner. A bladder scanner allows us to do see how much fluid is sitting in the bladder. And hopefully all of you in your clinical settings have seen a bladder scanner. If you get the opportunity to use the bladder scanner, I would encourage you to do that. This is one of many different types. We do different forms within our assessment, and we're going to do inspection, auscultation, percussion, and palpation. Sometimes we're going to listen to the left and right renal arteries to see if we hear any abnormal sounds. We're going to see if the patient has pain or tenderness with any pressure with percussion. If there is pain, it could be kidney disease. We're going to palpate the bladder sometimes to see if it feels full or distended. So when we assess the urine, we're looking at its color, and know that color can be changed by food, medications, and other pathological conditions. We always want to note its clarity, how clear it is. What do we see? Do we see sediment? Do we see just thick cloudiness? Can we not see through it? Is there an odor to it? And we always want to see the amount of urine and relate that to fluid intake to determine whether the patient might be fluid overloaded, or fluid deprived. Some diagnostic tests that can be done related to the urinary tract. These are some, and we'll talk about a few of those. When we look at blood urea nitrogen, or BUN, and then we also look at creatinine. Blood levels of BUN and creatinine are used to evaluate renal function. The BUN measures the amount of urea in the blood. Creatinine is the waste product that is produced by byproduct of muscle metabolism, and we see patients with kidney damage have an decreased urinary creatinine, but they will have an increased serum creatinine. We look at BUN and creatinine in relationship together. The normal BUN is 7 to 20 milligrams per deciliter. Elevated levels may indicate kidney injury or disease, such as diabetes or blood pressure, or blockage of the urinary tract. Sometimes we see it in high protein diets. You might see it in GI bleeding and other conditions such as dehydration and heart failure. There are also medications that can impact the BUN levels. Creatinine is filtered with other waste products. The amount of creatinine is directly related to muscle mass. A sudden rise in BUN and creatinine ratios occur in acute kidney failure and can be associated with shock, dehydration, and bleeding. Low BUN to creatinine ratios are seen in patients with low protein diets, muscle injury, cirrhosis, or SAIDH, which is syndrome of inappropriate antidiuretic hormone. When we look at the urinalysis, we look at its components. We look at the specific gravity, which tells us the balance between water and solutes. The higher the level of specific gravity, the more solid material is in the urine. We look at the pH. Acid-base balance of the body is determined by the pH. Urine is slightly acidic. Average pH is about 6. pH is useful in determining the kidney's response to acid-base balance. We look at protein. Normally, the urine doesn't contain protein. Protein in the urine can be associated with fever, hard exercise, pregnancy, or some diseases such as kidney disease. We look for glucose. Normally in the urine, there's very little to no glucose. If there's an elevation in glucose, we see this in kidney damage or disease such as diabetes. We also look at ketones. Okay, ketones indicate that fat has broken down for energy. Ketones are normally not passed in the urine. If we see a amount of ketones, that usually indicates diabetic ketoacidosis. We often may do a microscopic analysis to look for the presence of crystals, stones, bacteria, yeast, or parasites. We might, if there's a UTI suspicion, we might look for leukocyte esterase, which is the white blood cells in the urine. And you might see urine go for a culture and sensitivity, and this is where we want to see what organism is growing from the urine that is tested positive for bacteria. You might have a patient who gets a 24-hour urine collection. This is done to determine the amount of creatinine cleared through the kidneys in a 24-hour period. It can also measure protein, hormones, minerals, and other chemical compounds in the urine. Factors that affect the accuracy: not collecting part of the output, going beyond the 24 hours, spilling the specimen, inability to keep the specimen cool, or ingestion of certain foods. So when we have a patient on a 24-hour urine, we want to be sure that every urine that the patient voids is collected and put into the container. If we miss part of it, the 24-hour urine sample needs to be restarted, and we also need to stop it at the 24-hour mark. You can have an ultrasound of the bladder of your kidneys. This is used to assess the size, shape, location of the kidney. Additional technology that's available can also look at blood flow. These are safe for pregnant women and those who might have allergies to the contrast media. Factors that could interfere with the results could be obesity, if you've had a recent barium enema study, or you have a lot of gas or internal gas. You can get an x-ray, which is called a KUB, which looks at the kidney, ureter, and bladder. It's a diagnostic x-ray, and it looks to investigate gastrointestinal conditions such as a bowel obstruction or gallstones. Can detect whether a patient has kidney stones, and it can also be used to assess the positioning of things such as ureter stents. Patient could have an IVP or an intravenous pyelogram, which is an x-ray of the kidneys. However, we use a dye to see those, and we can get the size, shape, and position of them. We look for them maybe for stones, tumors, or infection. We can also do a CT of any of those organs. We can do a cystoscope, which is an examination of the bladder and urethra through a cystoscope, which is inserted in the urethra and advanced to the bladder. We can visualize the areas that don't show up well on x-ray. It can be performed to determine what is causing someone to have hematuria or dysuria, incontinence, frequency, urgency, or retention. It can diagnose conditions that cause the blockage of the urethra, and if we need a tissue biopsy of the bladder or the urethra, we can obtain that through this cystoscope. Here are various nursing diagnoses that are related to this system that might apply to your patient. Here's some planning that you can see, so you can just see how one might write that out. So there is collaboration and delegation within this system. We know that our UAPs, which are unlicensed personnel, which is like your CNA, is able to take the patient to the toilet. The nurse needs to be sure that they know whether or not the patient is on I&O, need to know whether they need to dump it or you need to look at it because you might need to know color or other things. So the nurse, there are nurse continence specialists which teach about pelvic floor exercises. Some physical therapists also do this, and they may also design an exercise plan to increase their overall muscle strength. Focus of goals are directly related to the identified nursing diagnosis. We want to determine which interventions are most appropriate for each patient, and we have to focus on activities that will help the patient who is compromised in their urinary elimination return to as much of a normal state as possible, and that if they aren't going to return to normal, that we also assist them with adapting to the change of this function. Ongoing assessment and follow-up are always needed to make sure that the interventions we're doing are reaching the goal we've determined. There's patient education and health literacy for patients with urinary issues. We want to maybe instruct families how to transfer individuals with limited mobility. We may want to instruct patients to respond to their urge quickly and avoid holding urine in, and this might reduce infection. We might want to emphasize their fluid intake and making sure that they're drinking plenty of water in order to keep urine produced. When to report symptoms and how to take their medications. Often we instruct patients who are taking a diuretic to take their diuretic in the morning because they'll get the highest response from that, and that could avoid patients getting up at the night and decrease their nocturia. We want to be sure that female patients understand aseptic technique in terms of wiping front to back. If you have a male patient who is uncircumcised, how to retract the foreskin and to clean their urinary meatus cleanly. We want to be sure that we stress the importance of drying area to prevent breakdown or irritation. If a patient's going home with an indwelling catheter, that we've done proper technique on perineal care, how to empty and clean the device, how to show them that it's a closed system. And if the patient happens to be getting bladder irrigation or flushing, we would need to teach the family that as well. So home care considerations, safety issues, can they get to the toilet easily? What assistive or safety devices do they need? What supplies do they need at home? And appropriate referrals and community resources. So practice alert, the home environment should be assessed, and distance to the toilet, physical layouts, and those things need to be reviewed so that the patient is not at a safety risk. How do we promote normal urinary patterns in the healthcare facility? We know that being in the hospital or a healthcare facility disrupts their normal routine. So we try to integrate as much as possible the person's normal habits into their daily care. We need to be aware that medications such as diuretics can cause frequency or urgency. This can compromise the patient's risk. So we want to be sure that we instruct all patients who are at a fall risk to please call for assistance before ambulating to the toilet and make sure that their call bell is within reach. These are examples of two urinals that can be used by patients. Urinals can be used standing, sitting, or lying down. Nursing care, so when we assist the patient with the urinal, we want to be sure that they completely empty their bladder because that will prevent complications. And we want to encourage routine use of the urinal in male patients. So that means we want to get in and empty them frequently or check to see if they're emptied. We want to be sure the urinal is within reach of the patient and the patient understands how to use it, or to call for assistance when they do feel they have to go. With documentation, we're going to document color, clarity, odor, and amount. And if at all possible, we might review with the patient how is their stream, and we're going to monitor whether it's frequent. We're going to look again at the urine assessment. We want to look at quantity. We want to be sure that we understand dehydration is something we want to avoid. If a patient is using the bedside commode, we want to be sure that it has a container underneath to collect the urine or the stool. We need to be sure we empty it and clean it, and that we assist the patient to the bedside commode for elimination. We want to make sure that if they are weak or unsteady, that they're calling for help before they get up, and we want to monitor if doing this activity increases somebody's shortness of breath. And it should not be used for a patient who cannot stand or is on strict bed rest. We want to be sure that we provide for privacy. We want to be sure we have a toileting schedule. That means that we offer the patient to go to the bathroom on a frequent basis, and we want to watch their fluid intake. Monitoring I&O, that includes food and oral fluids, as well as tube feedings or intravenous, generally recorded in milliliters. Ice chips are documented as well, and so most hospitals have a flow chart to let you know what a cup of ice chips equals to for their cups. For a general rule, generally once the ice melts, it's half the volume of the cup container you put it in. This is just a picture of a hat that would go in a toilet to be able to measure somebody's urine. It would be collected. But when we measure output, we look at what did they do in the bedpan, urinals, catheters, any drains, ostomy bags, NG output, any other collection devices, and we'll talk about drains and tubes another week. All of that counts in the output. We want to make sure that the patient has a positive balance of if they have a positive I&O balance. This is an example of a patient who has 900 more in than they have had out. Patient like this, we would probably watch them to make sure that they're not going into symptoms of fluid overload, and then we would just continue to monitor it, and if it were less than 30 mils per hour that they were putting out in an 8-hour output, we would notify the doctor if this gets overly imbalanced. Generally, the body will balance itself out. Then you'll see an output that's greater than the input, but we want to watch this. This is an example of a negative loss where the patient is actually voiding more than they have taken in. Quick quiz. Pay attention. So Kegel exercises, these help keep the female pelvic floor toned, and they can also reduce the risk of somebody being incontinent. If they're performed correctly, they've been shown to strengthen the pelvic floor and support both the uterus, the bladder, and the bowel. And improvement is seen generally in approximately 8 to 10 weeks of steady commitment to doing these exercises. So Kegel exercise technique, they're pelvic floor exercises. They improve the pelvic floor and help improve stress incontinence. And they can be done sitting or standing. And what do we document? We document that the patient has been provided the education on how to do Kegel exercises. How do we prevent UTIs? Prevention is key in UTIs. They can prevent them, prevent infection or reoccurrence. You don't want to wear very tight fitting clothes. We want to drink at least 8 ounces glasses of water or 64 ounces of water each day. We encourage patients to urinate when they feel the urge and not hold their urine. We want women to wipe from front to back. Women who have frequent UTIs to void after sexual intercourse. For women, often baths have shown to increase the risk of UTIs, especially with people who have frequent UTIs, so showers are preferred, and to have good personal hygiene. The treatment of UTIs usually requires antibiotics. They'll get some symptom relief quickly. Kidney infections may take weeks to resolve. Elderly people are admitted to the hospital very frequently for UTIs, and they need IV antibiotics. The statistics say approximately 80% of UTIs are the result of catheterization, so that's why we're avoiding indwelling catheters as much as possible in the hospitals these days. And when we talk on Thursday in class, we'll talk a little bit more about that. When is it appropriate to put a catheter in and those types of things. These are a picture of urinary catheters. A is what we would use to straight cath somebody. That means we're putting the catheter in just to drain the bladder for one time and one time only, and we are not going to leave it in. B is what would be called a Foley catheter. It's double lumened, and the urine comes out of the catheter into a drainage bag. There is a balloon on the end which is filled with approximately 10 cc's of normal saline, and that is to create a way for the catheter to stay in place, because it is staying in place. The C is what we call a triple lumen catheter, and that would be put in if we are going to irrigate into the bladder. Perhaps if someone's had a TURP or they're having bleeding in their bladder, and we don't want those clots to interfere with drainage or emptying of the bladder. We may do irrigation continuously, or we may do it intermittently. The last one is what we call a coude, and the difference between the coude and the Foley catheter, the coude type of catheter, is that it's got a little bit smaller tip and it's slightly curved. It will help us sometimes get around an enlarged prostate in male patients. So the most common is the Foley catheter. The coude, like I said, are special indwelling catheters that are slightly stiffer and bent, and it allows us to get through a partly constricted urethra, and the triple lumen is used for bladder irrigation. So this talks about the purpose of urinary catheters. Often they can be used to assess bladder function, obtain samples, irrigate the bladder, manage urinary retention, and allow healing after surgical procedures. And we will be going over insertion and all sorts of things and looking at them on Thursday. So thanks. Hi. Okay, so chapter 40 was about bowel elimination. We need to know that we're going to talk about the patient's bowel elimination function or dysfunction is part of our nursing assessment and part of what we do. It is the elimination of solid waste products and a normal function of the body. We need to know that it's critical to maintain maintaining nutritional status, hydration, fluid, and electrolyte imbalance. and it can be disrupted by various factors, and we need to understand the physiology of elimination, both the normal and the abnormal, so we'll know when our patients are having alterations. So this is the normal structure of the gastrointestinal system from the mouth all the way to the anus. That contrives a lot of various parts that play a role in how our gastrointestinal tract works. We know that there's chyme that's produced. Which is a thick fluid mass of partially digested food and gastric secretions, and it's passed from the stomach to the small intestine. We know that peristalsis is the wave of progression and contraction of relaxation in the walls of the intestine. This forces the chyme into the large intestine through the ileocecal valve and prevents regurgitation of the chyme. We know that we have the esophagus, which is a collapsible tube which connects our pharynx to the stomach. Our esophagus is a transporter of solids and liquids from the mouth and is where digestion begins. We know that food mixes in the stomach with our digestive juices and causing chemical and mechanical breakdown of food, and this produces the chyme that I just defined for you. The small intestine is both digestive and absorptive in its function. Intestinal juices and bile from the liver and gallbladder and pancreas mix with the chyme for digestion and absorption of nutrients. The large intestine is primarily our organ for bowel elimination, and peristalsis, as we talked about, moves things through this system. The colon is made up of muscular tissue that is able to expand and contract to accommodate and eliminate various amounts of waste and gas. The functions of the colon are to absorb, secrete, and eliminate. Serious electrolyte imbalances can occur with alterations in our colon. Water absorption from ingestible food and residue. We absorb nutrients, electrolytes, sodium chloride are absorbed from digested food, and bicarbonate is excreted in exchange for chloride. And the colon also excretes about 4 to 9 milliequivalents of potassium in a day. So then we have the rectum. Has folds of tissue, and these folds of tissue are what temporarily hold the fecal contents. Each fold has an artery and a vein that can become distended from pressure during straining. And when we have pressure from straining, this results in a distension called a hemorrhoid. Okay, so we have sensory nerves and the anus area, which helps control bowel continence. Feces and gas or flatus are expelled from the GI tract through the anal canal and out the anus. The act of defecation varies in amount and frequency among individuals. Some may go 2 to 3 times a week. Others may go several times a day. When peristaltic waves move waste into the rectum, the nerves of the rectum are stimulated. The nerves of the rectum are stimulated so that the individual becomes aware of the need to defecate. Fecal matter can be hard, it can be formed, it can be soft or liquid, and characteristics can be caused by varying issues such as diet, illness, medications, and age. So if we look at altered structures or functions within this system, there are some hospital patients who, when you're hospitalized just by the virtue of hospitalization, become at risk or may already have some type of alteration in their bowel elimination. Changes within their bowel elimination may be due to physiological issues such as surgical alterations or disease processes, effects from medication, or the lack of mobility or immobility. Some abnormal defecation patterns include diarrhea, which is a hyperactive bowel sound, an urgency, abdominal pain, and cramping, that the patient experiences, and they have abnormal frequency and fluidity of the fecal evacuations. These people have liquid stools. One condition that can cause severe diarrhea is C. difficile, and this can lead to life-threatening inflammation of the colon. These patients are placed in isolation when they have it and given some pretty strong antibiotics. Some patients may have incontinence, which is the inability to voluntarily control their fecal and gaseous discharges through their anus. For some patients, this may cause an impact on their body image. Patients may have constipation, which is infrequent or difficult bowel movements, fewer than 3 bowel movements per week, or often hard, large. So this is caused by slowed interstitial peristalsis, and infrequent bowel movements are the result. So then we have increased water absorption because the stool is sitting in the colon for so long, and this also impacts the difficulty to pass the stool. This may cause a patient to have excessive straining when they do have a bowel movement, and they may not be able to have a bowel movement at all, or perhaps it is hard or very painful. We talked about that straining during defecation can increase and cause hemorrhoids, but it can also increase the elevation of our interocular pressure. It can increase intracranial pressure. It can change our cardiac rhythm, such as it can slow it down by causing a Valsalva maneuver. And it can cause hemorrhoids that we've already talked about. An impaction is a result of unresolved constipation, and over time the stool becomes wedged in the rectum and the patient cannot pass it. Flatulence is what we call our gases that are produced in our colon, and severe flatulence can contribute to abdominal distension and sharp pain, especially if the patient cannot express it. Patients can have certain types of bowel diversions, which is a creation of a way for the patient to express stool that is not the normal passage of feces to the rectum. The patient may get an ostomy or a stoma. Sometimes they may be used interchangeably, although they are different in their meanings. Bowel diversion ostomies are created to divert and drain fecal matter. Bowel ostomies are classified by whether they are temporary or permanent, and also their anatomical location and the creation of a stoma. A temporary colostomy is used to allow the lower portion of the colon perhaps to rest or heal. This might be created in an emergency situation, and they're designed to be closed at a later time. If a patient gets a permanent colostomy, they will probably have lost part or all of their colon, and they are used to as a created treatment for colorectal cancer, perhaps patients with lower digestive tract issues due to illness or disease. And this is some locations of some different colostomies. You can see there can be an ascending colostomy, a transverse, a descending colostomy, and a sigmoid colostomy. And depending on the condition with the patient and the condition of the bowel will determine where the colostomy is placed. A loop colostomy is a temporary colostomy performed in a surgical emergency. It may result in a large stoma that might be difficult to manage. However, the goal of this is that at some point they will reconnect those two parts together. Or an ileostomy is the intestine that is brought through the abdominal wall from the stoma. Ileostomies can also be temporary or permanent and may involve removal of all or part of the colon. Stools from the ileostomy generally are frequent. They're liquid, and drainage is often hard to regulate. Remember that the drainage contains the digestive enzymes which can damage the skin if there's leaking around the stoma. And so when the patient wears their device continually, and we show them special procedures that are taken to prevent skin breakdown. There is also an ileal anal reservoir. So a pouch is created. It's not an ostomy per se because there is no stoma. In this procedure, the colon and most often the rectum are surgically removed, and an internal pouch is formed out of the terminal portion of the ileum. An opening at the bottom of the pouch is attached to the anus, so the existing sphincter can be used for continence. This pouch may also be called pull-through, endorectal, pelvic pouch, or J-pouch. After the initial pouch creation, the patient may have a temporary ileostomy so that the anal anastomosis has a chance to heal. You might hear a patient have a Koch pouch, which is a surgical variation of the ileostomy, and a reserve pouch is created inside the abdomen with a portion of the terminal ileum. A valve is constructed on the pouch and the stoma is brought through the abdominal wall, and a catheter or tube is inserted into the pouch several times a day to drain the feces that is in the reservoir that has been created. So some diversities considerations: lifespan. Constipation is the most common bowel management problem in the elderly, and bowel elimination problems are especially prevalent in long-term care facilities. We need to remember cultural, ethical, and religion issues. There are some races that have higher incidences of colon cancer. Disability. Does the patient have physical limitations or mobility limitations that may have difficulty with constipation or incontinence? Maybe they have impaired mobility, they can't get around to the bathroom very much, but that lack of mobility adds to the possibility of developing constipation. And obese people who often suffer from osteoarthritis, which causes a functional impairment and interferes with their activities of daily living. They may be at risk for bowel incontinence. Another quick quiz. So diet is a major factor that relates to the function of your GI system. We know that regular exercise promotes peristalsis and facilitates movement of chyme through the colon. Physiological factors can also affect function of the GI system. Anesthesia can block the parasympathetic stimulation and can slow peristalsis down, and that can cause a patient to develop a paralytic ileus, which is the stoppage of peristalsis. Some medications may directly or indirectly affect bowel elimination. We know that laxatives stimulate the evacuation of the bowels by changes in the GI transit time. And you may also heard the word cathartic. So assessment, we want to be sure that we do a thorough history, ask some general questions. If the patient is pregnant, are they having problems with constipation, heartburn, or gas? And some questions to ask the older adult. We also want to consider the patient's physical, mental, and functional abilities. We also want to look at the patient's environment, both and their family and social support. You might do a fecal occult blood test, which is the measurement of microscopic amounts of blood in the feces. Can be a sign of growth in the colon or rectum. You will hear it be called hemoccult, and we can do that right there in the hospital. Patients may also have a colonoscopy. The colonoscopies are used to visualize inflamed tissues, look for ulcers, abnormal growths in the anus, rectum, and colon. During a colonoscopy, growth can be removed or tissue can be taken for a biopsy. Some nursing diagnoses that relate to alterations in bowel elimination. You see constipation there, diarrhea, incontinence, self-care deficit, and disturbed body image, perhaps related to getting a colostomy or an ileostomy. This looks at planning for the patient, some nurse outcomes. So some evidence-based practice. So fiber in relationship to bowel health. Okay, fiber in the diet has many benefits, as we know. It can help normalize our bowel movements. It can help maintain the integrity of our bowel and the health of our bowel. It's been known to lower blood cholesterol levels. It's been known to help control blood sugars. It aids in weight loss, and it has the potential to help prevent colon cancer. So we always encourage patients to be sure they eat a diet that is fiber rich. And we know that if they do high fiber foods with an adequate fluid intake, most of those patients have rare problems with bowel elimination. So some nursing care guidelines. We're going to talk about the use of a bedpan. So bedpans are used for patients who cannot get out of bed. And there are two types of bedpans, a fracture pan and a regular bedpan. Some concerns: we always want to be sure that we wear gloves when assisting a patient with this type of elimination. We want to be sure that we've placed a waterproof pad on the bed that the best bedpan will rest in, that will absorb any fluid that perhaps misses the bedpan, and therefore the patient won't require a complete bed change. We want to always be sure our patient is positioned properly. The buttocks should be centered in the pan. If the patient is unable to assist with lifting or movement, we roll the patient, place the bedpan, and roll them back onto the bedpan. We want to be sure that we document this on the I&O, and we also want to be aware of the patient's tolerance to the procedure, and we want to do a skin assessment of that area because we'll have visualization of it at the time. This is a picture of the two types of bedpans. One is the fracture pan, one is the other, and just some descriptive characteristics. Are there legal, ethical, and professional things? We're responsible for providing competent care to reduce risk of infection and maintain patient skin integrity related to bowel elimination. We know that the longer the patient is left on the bedpan, it can contribute to ulcer formation. So this requires that the patient have their call bell and that someone responds to the patient quickly when they do call. We want to be sure that we're cleaning the area well, and we're applying any barrier creams to the skin, which will help with skin breakdown. And we know if our patients are incontinent, we want to limit the exposure to the moisture and the bacteria. And as always with this, we are doing frequent skin integrity assessments. This is a bedside commode. It's a portable toilet chair. There's a receptacle underneath to catch the contents. Generally used for adult-sized patients, and it's for a patient who can get out of bed and perhaps they have ambulatory difficulties and they cannot walk all the way to the bathroom, but they can stand and take a couple steps or stand and pivot and sit on a bedside commode. Always remember that safety is very important when a patient is on a bedside commode, as to whether or not the patient can be alone, whether or not the patient is at risk for falling, attempting to get themselves back to bed. So we need to be sure that we do a good safety assessment when using a bedside commode with patients, and be sure it doesn't have wheels. If it does have wheels, that the wheels are locked. So patients might need a rectal suppository to either give medication such as Tylenol, sometimes antiemetics and other medications because they're unable to swallow from excessive nausea and vomiting. Or they might need a rectal suppository to assist with elimination of their stool continence. Some laxative, cathartics, and laxatives come in a suppository form. And laxative suppositories work to soften the stool and distend the rectum to send more signals to push the stool out for the patient. Sometimes you might do an anti-diarrheal suppository I don't know that there are really, I've never seen one. But your patient may take oral antidiarrheals to slow their bowel movements down. You may have a patient that requires the need for an enema. An enema increases volume of fluid. It will distend the colon. It will irritate the intestinal mucosa lining, and it will stimulate peristalsis to complete evacuation of the lower intestine. They are commonly used for relief of constipation, removal of fecal impactions, emptying the bowel prior to a diagnostic surgery or diagnostic test, or perhaps right when beginning a program of bowel training. There are several types of enemas. You can have a cleansing enema, and they can be hypertonic or isotonic. Oil retention, medication enemas, return flow enemas remove gas that is trapped in the intestinal tract. And we'll review proper enema technique when we are in class on Thursday. This is a chart of the different types of enemas and what they're used for. So there is some collaboration and delegation. Most patients with ostomies that are going to be left in place or be discharged even temporarily will need to learn self-care. And that's going to be started in the inpatient setting or acute care setting. So if they're going to undergo surgery or they're getting a new one, we want to be sure that if our hospital has a wound or ostomy nurse, that we've put in our referral and that patient is seen quite frequently, because generally if they're certified, that's their expertise within the nursing realm, and it's good to get them involved right away. Nutritional counseling always helps to manage the diet, to help with plan with foods maybe that create less gas, because if you have an ostomy and you have a lot of dietary gas, your bag is going to fill with that gas. And or manage elimination issues. There might be the requirement need for mental health professionals, because we may have anxiety or depression or alterations in their body image. And this is the picture of a stoma. A has the stoma looks very nice and it's intact, and the skin around it is healthy and pink. When we look at B, we see that the skin around the stoma, it's still a stoma, it's small, but the skin around it is very excoriated, and we don't want B. Some home care issues. Are that we want to be sure we do good patient education. We want to know if family or significant others or their social support system that are available, we want to be sure they're included as well. And we're going to want to, they may also help the patient be ready to learn. Patients may be apprehensive, so it may be slow starting, but with good encouragement and good education, patients learn to participate in their care. There are different ways to teach them. We want to be sure that we not only psychomotorly show them how to do it, but that we provide some literature to go home with, such as step-by-step manuals, maybe supplemental DVDs, and access to websites. We might want to evaluate the patient's home as well for any bowel concerns. Another quick quiz, and we're on the last side looking at evaluation. So we're going to evaluate our goals and outcomes for the patient with bowel elimination problems to achieve the desired outcome or goal. Remember, our goal is to return to normal bowel function or maintain existing function within the parameters of the patient's condition. It's important for the nurse to determine whether they have been met or not met and why, and that involves evaluation, implementation, reevaluation, maybe change in interventions, reevaluation, and just working the problem until we get it solved. We also want to make sure we understand the patient's current food and fluid intake, medication, activity level, and knowledge about their bowel concerns or bowel issues within their normal daily routine. And We want to evaluate this so we can get them back to as much normal function as possible. Thanks. Have a great week, and we'll do some more on Thursday, more visually, how do we do this in the lecture on Thursday. Have a great week, and I'll see you then.